Welcome to Sports Doc Talk. I'm your host, Will Sanchez, joined as always by our orthopedic surgeon and sports medicine specialist. I'm so choked up. I'm already getting so excited. I know you're excited, Dr. Garcia. We've got a tremendous guest today. We're going to talk about one of the most exciting and evolving areas of sports medicine: cartilage restoration, joint preservation, athletes. I can't contain myself. Dr. Garcia, how are you? Tell me how excited you are for our next guest.
I'm super excited. This is we've had a number of podcasts. You've probably seen his picture too many times on my PowerPoints. We've talked his podcasts on the recent athletes, which we'll talk about as well, have been huge hits, and everyone's talking about it. Even today, I had a patient and meniscus transplant, cartilage transplant, and they're like, "Hey, what's that surgery like?" And I'm like, "The one Lonzo Ball had." They're like, "Oh, okay, I got it." So they move on.
Yeah, and we've got a lot of feedback from that, so we're really excited about our guest that's coming on. But first, let's talk about the great people over at the Recovery Shop, especially Mike B. Dr. Garcia, tell us how you utilize Recovery Shop in your practice.
Yeah, so big thanks to them for our sponsorship. Again, really key for me, especially with these complex surgeries, right? They offer these sort of aftermarket products, improved bending machines, improved ice options. It's really great for me, especially nutrition and other recovery options that the patients can't get normally. So it's all one bundle there for the patients to access it, and it works really great for these complicated surgeries. So thanks again, guys, and any surgeon interested, let us know.
All right, listen, I normally introduce the guests, but this is your guest. This is your mentor. In fact, we should be giving him money because we've brought up his name so many times in our shows. I mean, he may ask for a cut. Let's just make sure if we're all right with that. Why don't you introduce our guest today?
Yes, so I'm super excited to introduce Dr. Brian Cole. He is professor of orthopedics at Rush University, where I went to fellowship and learned all the cartilage and meniscus and osteotomy surgeries. He's also managing partner at Rush. If I went through all the things that he does, we would have no more podcast time left. So thank you so much for being on the show. We're so excited to have you. Will you give us, I know I don't want to get into, we have so many questions for you. Sure. Will you give everyone kind of the background as to what got you into this? I mean, there's so many things you do, but what got you into the cartilage stuff? That's the meniscus surgeries. These are now more mainstream, right? Because we've learned them from you. But when you were doing them, they weren't really mainstream. So why do this? Like, why go in this innovative sort of potentially risky options that no one was really doing a lot of?
Sure. I mean, I think that's a good way to start the narrative here. And Will and Grant, thanks for having me on the show. So look, when I was a resident in sort of the mid 1990s, we really only had two options. There was debridement and marrow stimulation, and that was pretty much it. And that really wasn't that long ago. When we think back, one of the first publications on marrow stimulation by Dick Steadman was in the mid 1980s. So what typically would happen would be that a high-level individual would get an arthroscopy, and they would get transient relief, and then there would be really very little else that could be offered to that person. When I came out of my fellowship after my residency, we really only had a couple more things. It was an osteochondral autograft, and it was ACI, and we were starting to see the introduction of osteochondral allografts, but graft availability was a real issue. And we really had no framework to have sort of that balanced decision-making, and there was very little in the way of evidence-based medicine. So at that same time, there was a ton of new innovation happening. And we were starting to see laboratory studies, we started to see some preclinical work. So it's a very exciting area, but there was really no framework to make decisions on it. And that's what I found most interesting. I just felt like it was a huge white space to say, look, like to your point, Grant, it is risky when if you choose to be an early clinical adopter because the outcomes are difficult to predict. And that in and of itself has inherent risks in terms of educating a patient and managing expectations. So when we started initially, when I came to Chicago, I was recruited by also one of your mentors, Bernie Bach. There was really no one who had an organized infrastructure to manage articular cartilage problems, most commonly in the knee, but other joints as well. So it was the opportunity, I think, at the outset to say, how do we be proactive, do things prospectively, collect every data point possible so that at some point that data becomes relevant and we can start to make informed decisions. And that was really it. It was a challenge. It was an unmet need, huge white space. And we really didn't know when to apply the limited solutions we had. And we were on the forefront of actually having a number of new solutions that we would have to start considering in terms of early or delayed clinical adoption.
And do you think that this, I mean, one thing that we can talk about is we're going to show all the things you're involved in. And it's not like you did this interesting surgery and then all of a sudden you were done, right? It's like the next thing, you're the next thing. You keep doing the early adoption and you've built up the background to that. So is that for you, is the drive there just to continued early adoption, or is there other drive that gets you going to do that stuff?
No, to be honest, while the outside looking in, you may say I'm an early adopter, and I guess relative to others, I am, because I'm exposed to new technologies. But my adoption has always actually been fairly measured and in a tempered way, because the first thing is I always needed to feel that whatever I was going to do was going to be safe. And even if it wasn't proven as far as efficacy, I needed to know that it was safe. So there were people around me, peer groups and so forth, who would jump on a new innovative solution even before I would. But I just needed to know that it was safe if this is something we were going to do. And that even became more challenging as more options became available. And I think one of the difficulty in sort of balancing innovation and research is that as you get more and more options, when some of them start working and then a new innovative option comes around the corner, you and I are no longer equipoised to say, hey, we're willing, we acknowledge we have a problem with an existing solution, balanced against the patient who's no longer equipoised in terms of making a decision. It gets harder and harder to introduce new options because we actually start to get things that work. So the balance is tough, but I would say that while it may have been perceived that I was early at the outset, I was actually, I think, pretty conservative. It's just that things kind of came our way, mainly because we were tracking prospectively virtually everything we were doing, and we started to report our successes and failures early on. So we had a fertile ground of patients who actually needed these treatments. But this concept of equipoise is pretty evolutionary, and it got more and more difficult as time went on, as solutions started to prove themselves out because of the data that we were actually collecting, if that makes sense.
That does. I knew this was going to do this. So you got a great point there, which I really want to hear more about this. We have solutions that are really good that are time tested, right? One of Macy cartilage transplants are some of the most studied studies, and a lot of them are yours. But now we're going to show the slide in a second. We have solutions that are newer, that are still not fully time tested, and maybe success rates are different. What pushes you to that direction? And we probably can get there in a second. Is it that it no longer fits? You have a new niche for it? Is that the idea? Is that what it's going to look like here? Or is it that sometimes, the patient indication, I mean, you're a different animal because you have such a busy practice and you have so many cartilage patients, but for a newer surgeon where marketing is a big deal and you all of a sudden patients saying, I saw online that this is the best surgery, right? And it's a pretty good surgery. Maybe it's not as good as the one you normally have. Do you ever deal with that? Or is that just not something you have to have an issue with?
Yeah, I mean, I think the concept of marketing is a dicey area, to be quite honest. And we either have a presence by association and by our successes, but truth be told, one patient begets another patient when you have a good outcome. And I think that when you start on the clinical adoption curve, we all have to do it in a very measured way. And I would just say it doesn't provide an excuse to take a shortcut to try something new. What I am finding is that these new procedures are filling some white spaces. I think we've done a pretty good job. We're sort of in the 75% predictability zone for when we properly indicate a patient and they undergo some type of joint preservation procedure, where we can pretty much predict that they'll get some benefit, not necessarily an off switch, but some benefit that will be appreciated by them. We also now have identified that there's a growing group of people who are, for example, not good candidates for arthroplasty. They don't have sufficient joint space narrowing. They don't have the risk. They don't want to assume the risk of high level activities, which may lead to premature failure. And frankly, when you look at the response rate and those who meet the MCID and so forth, when it comes to arthroplasty, it isn't always as predictable and glamorous as people really have come to recognize. So even those who do knee arthroplasty as a primary surgical procedure would probably readily admit that outcomes can be tempered, and they're most tempered in that mid zone, that sort of gap patient, which still has some joint space. Despite having arthritis, what you and I see at the time of arthroscopy, it's actually joint space which predicts success or failure in many of these individuals. So they're not only young age, are have an aversion to a failure of a mechanical implant and then thus revision surgery, they actually don't do as well as those who have true foregone osteoarthritis that would otherwise respond to it. So that leaves an enormous white space, especially as people desire to remain active. And that's what I think some of the new technologies are leading us to, is we're doing pretty well with localized cartilage defects. We've done much less well with early arthritics. And I think that's the area that I think we're going to see sort of the greatest improvements, because that's a very large population that still is relatively untapped in terms of finding predictable solutions.
I think that's an excellent point. Will, can you bring up that slide? I think I want to do the 2 slides with Dr. Cole right now to show them. That one's really good. So we've talked about a lot of these surgeries ad nauseum, even briefly some of the last bits. Will you go through this briefly, kind of your perspective, because this is your slide, and it's a great discussion point that you just brought up.
Yeah, it's just a way to sort of give you a high level to say, where are we now, And the great news is the slide gets to be updated because we're in a place where we have some new solutions that have passed through the FDA process. They have proven to have clinical efficacy in the eyes of the FDA, which is probably the most difficult judge of all. They are the subject of level 1 studies. They are being compared to things that you and I would consider maybe previously a standard of care for some challenging patients. And you can see how it's expanding. The numbers that you see here are really the relative frequency of these procedures being performed. And truth be told, we're sitting around the 3,000 mark for cell-based technologies such as MACI, formerly known as ACI. Osteochondral allografts are sort of in that 4,000 procedures per year range. But there's still a lot of debridements being done, and it's worthy of discussion at some level, because debridement is a viable option to treat patients based upon their timelines, and it's a very important one when you're dealing with high-level athletes. And then we also have that sort of point of care opportunity, procedures such as marrow stimulation and adjuncts to marrow stimulation. And then as you sort of move through the lineage, we start to see that we might actually have the ability to treat patients, like I was just talking about, who have osteoarthritis, but they're not sort of what we call Kilgore-Lawrence 3s and 4s, where they're bone on bone, but they truly do have osteoarthritis, not localized defects. And that patient group is a very challenging group to offer some of these other solutions to get a predictable outcome. So that's the one that's become very interesting, because from a epidemiologic perspective, that's a big group. And we need to start finding solutions for those patients, which may not always be surgical, by the way, but something that can be joint preserving without the need for metal and plastic, that can yield a predictable result, something at or better than that 75% range.
Well, I think this slide's really important too. And I think you mentioned it, right? That as much as these are sexy surgeries, we've seen them in marketing. As surgeons, we see these. I do cartilage, obviously you learned it from you, but it's still not high volume, right? This is really not that high volume compared to the debridement and the other things, right? So we're still in this learning phase for some of these surgeons. Would you agree with that? Or we're not
Yeah,
seeing
no, I think it just speaks to the fact that this is a niche area, and there's, as we make decisions, we get better. We learn more from our failures than our successes, but these are not high volume procedures. I mean, I've been doing this 26 years. Over 26 years, we probably, I have my practice is sort of shoulder, elbow, knee, but my knee practice is either ligament or cartilage. And the cartilage practice, despite having a referral center, maybe we do 50 osteochondral allografts a year, maybe 60. I still probably do way more non-surgery and education and reassurance than surgery. Same thing for meniscal allografts. Over 26 years, we've accumulated about 1,500 osteochondral allografts. Now, that sounds like an enormous number, but that's 26 years. So you do the math, that's not a lot per year, right?
Well, so for all the listeners, that's a lot for everyone else except for Dr. Cole. That's normal.
I mean, I think it's a big number, but in the scheme of, like, when you think about things, compare that to 500,000 ACL surgeries a year, compared to 300,000 meniscectomies done a year, So it's still a relative niche area that and the things, and if we get outside the indications, then we've got real problems. So I think the things that we've gotten better at, because we have data, is actually understanding our failures actually more than our successes, and looking at large databases. This is where we can talk about it later, but this is really where AI will have a role in terms of actually taking real data and helping us make decisions from a multivariate analysis that we couldn't really do before. So at any rate, to your point, they are infrequent, not frequent procedures. And I think they'll probably remain that way because it's on us to actually decide who is actually a good candidate where we're going to do something to them and meet their expectations.
Well, and you just brought this up, and I know Will wants to say something, but we always get these good back and forth.
Mhm.
The point you made that was really good. I had, you brought this up on multiple times. I've had talks with you, but the number of patients that you see that have had a meniscectomy or that you do a meniscectomy on that need meniscus transplant is actually quite uncommon. But the number of patients, at least in my office, that I do a meniscectomy on that ask about meniscus transplant is far more common. Or the patient that comes in saying, I think I need to have a meniscus replacement. And you're like, you're not even there. You have no pain. You have no other reason to have it. And I learned that from you. I think that's really important that you keep saying that, is like cartilage surgery actually is a vast majority of non-operative treatment. For the right patient, you need to do surgery for them. It's just that it's really sexy. So people ask about it all the time.
Yeah, I mean, I guess it's gotten less sexy over the years for me. It's become fairly routine. But I would say that cartilage surgery is for the here and now until we prove that we're disease modifying or being preventative in nature. It comes at a real cost to a patient. It comes with a high amount of variability in the outcomes, a degree of unpredictability, and timelines to get back to the routine things. It's not just back to sport, but just getting back to their life. So the decision making isn't to be taken lightly, which is why I think some lower level procedures are gaining favor, because you can actually achieve very good outcomes by doing less.
I think that's really good. Will, you had a thing you were going to ask him.
I mean, it was funny. I just listened to the conversation. Every time I was going to, add something to it, you talked about that, right? And you talked about, that balance, right? And I think, patients kind of want to hear that the balance between innovation and being on the cutting edge, but also being practical and making smart decisions, safe decisions. How does a young surgeon that maybe doesn't have the confidence where they're at in their career balance those decision making? Is that just making sure that you're doing your homework, doing the practices, feeling confident on the procedures, or is there something else that you can kind of give advice? I guess what I'm doing is tapping into your mentorship part of it. And what do you tell future surgeons on how to have that balance going forward?
The classic mindset of a young surgeon, and just going back to what happens in training, is that they want to do something and they feel there's a need to do something. But when you really look at the human condition, when patients come to us in our practice, we don't always have to do something to actually meet their objectives. And I think that if you don't listen to that early in your career, it can take years for you to develop and understand that. But I would tell young surgeons that patients have concerns. They're concerned about the past. They're concerned about how did they get there. They're concerned about the future. If they don't do something today, they will miss an option that they could otherwise enjoy today that they won't be able to do later on, or they'll be pushed to a place where they'll never be able to be made better. Right. So if you spend, for young physicians, not just surgeons, spending time understanding what a patient really wants is probably the most important aspect of the physician-patient relationship. I will often ask a patient, look, on the way to your visit today, what were you thinking? What would you most like if you decide to treat? And that's a lever in and of itself. Should you or shouldn't you treat? What would you most like to see happen? And based upon that answer, this is where young versus experience can be differentiated. Based upon their answer, you kind of have to know what you decide will deliver for that individual if you're going to meet their expectations. Mm-hmm. In many ways, I use this analogy. We're often like a waiter. I've never really liked the question when a waiter comes to the table and I'm eating dinner with someone. They say, "Well, what's your favorite thing?" I mean, honestly, I don't really care what the favorite thing of the waiter is, right? Because he might like liver, and like liver makes me gag. So the point is that a waiter should be able to describe the food, what they do well, and what you might experience if you order that. Mm-hmm. And if what you order consensually, if you will, in this instance, meets what you'd like to see happen, then that might be a good decision. So sometimes people say to Grant's point, look, I just had my meniscus taken out and I read something and I don't want to get arthritis, so put one back in. Well, a meniscal transplant can take 5 to 7 or 8 year or 10 year maybe stent that goes in the knee that reduces pain, generally speaking, while it's there and functioning well enough. But very few people have shown that it will prevent the onset or progression of arthritis. Now, that is changing. We're starting to learn that, for example, a meniscus transplant can be contraprotective, but to do it in an asymptomatic individual who is meniscus independent, who can play and do every single sport, not worry about torturing a meniscus, and then put something in there that they can now torture in a setting where they didn't have pain to begin with, under the premise that you're going to protect them long term, that's still a reach. So I think in summary, you asked a great question. It's provocative to be able to provide solutions to patients, but this is a marathon. It's not a sprint when we go into practice. And I think the satisfaction of taking care of people is greatly enhanced when you start to think about each individual, not necessarily by what their finding is on their MRI at their time of arthroscopy or what they think they want, but rather getting inside their heads and understanding what their concerns are. You might come up with a very different solution set early in your career than you would otherwise, just because you have a hankering or a desire to sort of use the newest fangled thing or the newest thing that just got introduced, through the FDA. Those are just, and look, if you asked me that 15 years ago, I might have given you a different answer, but I had the luxury of time, and this is where level 5 evidence comes in. We discount level 5, which is basically experiential, because it didn't go through the rigors of a level 1 study. Look, a lot of level 1 studies are flawed. Randomized double-blind comparative studies, a lot of them are flawed. Think about the people who choose to go into a clinical study. That's not a regular person, right? Especially if they're not what I said, equipoised, where their solutions are actually working. They're thinking that whatever is out there isn't sufficient. There's a strong belief that they want to have a successful outcome, and entering into a clinical study is not real life. So level 5 is actually important. And as we accumulate level 5 year after year in seeing patients, if we have that intuition we develop over time, which does take time, I think we all become better physicians over time due to that level 5 experience. So I would say that I'd say what I'm most proud of is that we'll see between 8 and sometimes 10,000 visits a year with my team. And while we may operate on 900 to 1,000 people a year, if you look at the math, we're really doing more counseling and education and non-surgical care. And as I sort of alluded to, that gets actually more satisfying as you get through further on in your career. And as you filter out patients who really need surgery to get better, your success rates just get better and better. That is just a known foregone conclusion. And I would say in order to do that, you can't do it like it's a cliche, but you can't do it without a team. And the people you surround yourself with have to really be as passionate about these ideas as you are. And Grant, you remember when you were a fellow, like I love my team. Like the thing that will prevent me from retiring is because I still love having clinics on Mondays. I love having clinics on Thursdays. I'm happy to show up in the morning. There's people who are eager. They're always asking excellent questions. They keep you honest. You feel like you're always at the forefront, and they're not going to let things slide. And the quality and the ability to help many people is incredibly satisfying. And I would say the only way it gets done is by having a deep bench, and a deep bench of people who you can actually ask or understand what do they want to get out of it. And they've got to be part of it. People are not valued by salary. They're valued by the passion they have for the job and feeling valued for what they do. There's a great book, this book Drive, which I just started recently reading. And if you look over history, there's a lot of decisions people make that stay engaged that have nothing to do with financial success or compensation. We all have this intrinsic goal to do good. And when you think about it, when we go into medicine, most everyone goes into it initially because they want to make a difference in people's lives. And that's, at some point, it will become clear, because if you're doing this for these days because of the bureaucracy and all the things that we're faced with, and the decreasing decision-making power and independence and so forth, physicians are going to get frustrated, and they're not going to turn to medicine. So anyone who's currently going into medicine now really has to, I think, truly be in it for, the intangibles that will give them a satisfying, fulfilling career where it's not really considered a job. And the way to get it done is you surround yourself by like-minded people who in some instances are actually much better than you. and making sure that their goals are also being fulfilled, just like your goals, Grant. When you say, look, what is satisfying to you, making a difference in someone's life, they too have those same aspirations, same goals, and you got to have a deep bench. I'm really overcapitalized in FTEs. That's one area where I will not take a shortcut, because I want my patients to have access, and that means they have my email. They often have my cell phone. It's very rare that they abuse it, and they need to know that just because they don't have another scheduled office visit, or they may have questions later on, they will have the opportunity to actually to do that and close the loop, because access to healthcare is one of the biggest problems right now. And I will say that my patients, about the only complaint I get is they wait too long in the office, but they will uniformly say that the experience was good because they got their questions answered. And that's a really tough balance, because I hate being behind in the office. As you remember, it's like the most daunting thing during the day, But
now I realize I got that from you as well. So now I'm
yeah,
going, I'm just checking off all the boxes.
right. You still have to give them what they came for, and they need to feel
100%.
cared for, and they need to feel that we satisfied the reason they're there in the first place. So at any rate, it's a team approach. I know it's a cliche. People use that all the time, but it's true. And it's a reason that concept gets brought up time and time again. It's pretty time tested.
Well, also, I would say, I mean, I don't want to bring up just the cartilage and meniscus, because obviously a team approach is everything in medicine. But with cartilage surgery, like when I started, I was like, I need to have a scheduler for cartilage transplants, and I need a scheduler for my MECs or my other cartilage surgeries, because that's what you did. And that's how that works with those surgeries. You need even more help to be doing these really complicated ones, extra insurance approvals and things like that. So the team is extremely important. And you don't have that, which, you do a ton of talks. I do some talks and talk about this with other people. Like, you can't be successful in these challenging cases. It just doesn't work like that.
The cartilage thing is a burden, because like you pointed out, and the insurance process is very demanding. Now, though, we're seeing peer reviews for virtually every, even simple procedures. So that's just becoming the norm, and so the cost of delivering care is just going up exponentially, because the insurance companies are putting this in this position because of the peer review process. But logistics of scheduling, especially if you're doing concomitant procedures, having the graft there on time, making sure the patient schedule fits the patient's schedule. This is in many cases, it's a gift of human life, and from human life, I should say. And you got to have your ducks in a row and everything lined up, because you can't have a graft show up and the patient not be there, or not having insurance approval. So we have a big responsibility. If you're in the joint preservation business, if you will, there's a lot of boxes you got to check, and you do need more infrastructure than routine things, although that's changing for virtually everything we do right now in healthcare. Unfortunately, you kind of have to, the FTE problem, maybe it'll be solved partially by AI, but it's still a very big issue. The HR problem in healthcare is not getting any easier.
Will, I think, was going to bring this up too, but I want to know, like, what do you say when, you have your fellows, right? And that's a different animal. I mean, obviously they go through your rotation, they get your background information. Like when I started practice, it was like, I have all my authorization letters from Cole's office, so I could hit the ground running. I mean, going into doing transplants and meniscus transplants my first year in practice is not a small feat, after, even from experiencing with you. But what do you say for some of these people? I mean, it's pretty daunting when someone's like, I want to come in and start doing these cartilage surgeries, and they haven't had a strong fellowship. Like, how do you give them advice? Do you have people that ever come? I mean, I'm sure people ask you at these meetings and stuff. What's your advice for a surgeon that has very little experience, they want to get into it? Because I mean, after seeing it with you, I was like, I think I might be able to do this. And I had to practice in the lab more, even after being in fellowship, because they're not easy. So how do you tell that to the young people that don't have that type of experience?
Yeah, so you asked a good question. And I think, one of the greatest blessings that we have is that we're always a student. There are not too many people, if you think about your friends who do other things, or private equity, or invest in banking, or real estate and other, they probably wouldn't be able to say the same thing. And we never stop learning. So I think there's a lot of opportunities for mentorship. The hands-on experience comes through the Orthopedic Learning Center, through courses for ANA, for AOSSM. It comes from ICRS, who has these courses, but it also comes from these traveling fellowships. So I think if you're interested, if an individual is interested in understanding the dynamic of joint preservation, you really have to be comfortable in the non-surgical management. You have to be comfortable in orthobiologics, where they play a role. where there's evidence, where you might want to use them either in an office setting or as an adjunct to operative care. You need to be absolutely comfortable with realignment procedures, osteotomies, meniscal allografts, and every cartilage procedure, because they just don't live in a vacuum where you have a cartilage defect. So that's the daunting part, that you can learn it after, if you're a good surgeon, you're a good arthroscopist, but you haven't learned joint preservation, cartilage repair. It's doable, but look, I got better over time. I only had a few things I learned in my fellowship. What we've done, though, I will tell you, is the field has gotten so advanced that it can put joint preservation in the hands of people who didn't get a fellowship in it. Meniscal allograft transplantation is an easier operation now because the instrumentation is much more streamlined. Osteochondral allograft transplantation is 4 simple steps.
So will you tell me, so one thing I know we talked about kind of is this traveling fellowship, learning it, but how do you feel? I mean, obviously I don't want to be asking a question about myself, but part of the reason, one thing that's really big deal for you is everywhere I go, it's like, okay, this person trained with Cole, this person trained with Cole. So like, how does that motivate you as well? I mean, not only do you get to teach, but everything you learn is now expanded massively. It's just not that common. I mean, we all have people that we learned from, but for cartilage surgeries, especially these cartilage meniscus complex surgeries, the number of people that I can think of that I speak with on these podiums and talks that have worked with you it's vastly overwhelming compared to many other different mentors. So, and you're one of many, but it's just, what is that to you? Like, how does that influence? Does that change anything you do? Or is it just really cool? Like, what is that for you?
Yeah. I mean, look, that's the greatest privilege of all, is being able to be a mentor. Like, when you think about like, what's your legacy and what are you going to be, what are some of the things you'll be most proud of? It's the people that I've had the opportunity to work with. Like, when I see you on a podium, or we have these panels, like it's to the point now where the people I've trained 15 plus years ago are people I listen to, and I'm like, well, what are you doing now? How are you managing this problem? So the coolest part of it is that, that may have set the foundation. They learned the decision making at the time that they were a fellow, and then they also learned the techniques, and then they practiced the techniques, which is one of the greatest things that we have, is all these different learning environments. We can assume new skills. I'm still assuming new skills. I mean, there's things I do now that I didn't do even last year. So we're always a student. The greatest thing is seeing how you evolve in your career, and you actually are an original thinker now. So I trust your judgment. I would ask you and I actually have second opinions together. I saw Grant Garcia, and this is what he said, and I'll say either I agree or this part I might think about differently. I mean, there's room to agree or agree to disagree, because there's a lot of variability in terms of how we make decisions here. And it doesn't mean it's improper or beyond the standard of care. It just means it shows that this is still a bit of an art, and has a lot of level 5 behind it. So the mentorship piece has been again, one of the most satisfying aspects of my career. But look, there are other programs, and there's other places where people learn cartilage, but because we talked about before, it's a low incidence problem. If you're really interested in your training and you're a resident, and cartilage or joint preservation is something you would like to pursue, and you're going to do a fellowship, you really should look to fellowships that have some volume, because there are it is hard to teach, and you don't get a ton of hands-on experience in some places as a fellow, but you see a lot, and then you get to do and you learn after you're out. And we all get better as surgeons year after year, and there's plenty of different learning environments. Like, when I learn something now, I actually go to a lab. I mean, I didn't know
100%.
I didn't know how to do Misha. I went to a lab, and it took me 2 hours after I read it, and I watched a video, and I didn't know a CartiHeal has some nuances to it that it's not like any other cartilage procedure. You got to learn these things. Macy, Arthro-Macy, we have the greatest job ever, because all we do, we just keep learning new things, and through innovation, for us to stay on our game, you got to be a student all the time.
I think that's really important for people to hear that. I mean, you have expert at this stuff, still training, still learning new things, still going to the lab. I'm doing something new. I'm doing type of meniscus transplant. I'm going to the lab in 2 months, try to figure out how to do it. Cause I'm like, I'm not going to test on the patient, right? No matter what you do. And it's just awesome to hear that. That's the drive, as a younger surgeon saying, well, Cole's still doing the lab, so why would I ever not stop doing it? Right. Like, he's willing to learn still, like, I'm going to do it. So anyhow, I don't want to belabor that topic too much. I want to get to the last topic, because obviously this is the one that's the sexiest. It's in the news, but very briefly, will you talk about how your cartilage considerations change with the professional athletes that you take care of? Because not only are you cartilage meniscus surgeon, but you also are cartilage meniscus surgeon to professional athletes, which is extremely uncommon.
Yeah.
Show that slide. We can show the two major athletes that you've been involved with to talk about that and pull that up. So this is actually from one of my PowerPoints. I gave a talk on this and showed these two players because they've been on our podcast, not the players, but the conversation. And both times we've talked extensively, but these come up my office all the time. I mean, these conversations for both these players, mainly Lonzo Ball. You don't have to go into too much detail, but maybe talk about the Lonzo one a little bit more and kind of how, I mean, that was the first time, right, ever in an NBA that a player had a meniscus transplant?
To my knowledge, yeah.
Yes.
Yeah, I mean, I think.
And so why? Yeah.
Athletes are, athletes propose a very unique decision-making process. It's complex. There are a number of stakeholders. There are, beyond the disease state itself, there are a number of aspects that are relevant. Their age, their contract status, the position they play, the sport they play, roster changes. Like there's at least 15 independent variables that weigh into how we make a decision, which may not be the same thing for an otherwise active patient who's not a professional athlete. The most important determinant of an athlete deciding consensually to undergo a joint preservation procedure is the fact that without it, they cannot otherwise play their sport or play it at an acceptable level. If they can play in pain and play at an acceptable level for themselves or the organization, we're not discussing a procedure that might even make them worse or not deliver an outcome that they would otherwise not even need. So there's a go or no go when it comes to a professional athlete. And that's that, look, if you were told that you have permission to play in discomfort and that there is not concrete data that says that physiological loads and other will make this inexorably progress, it might or could. It for sure might or could elevate your symptoms. But if you could tolerate them and play your sport at an acceptable level, why are we talking about doing anything surgically whatsoever? So that's the first thing, because when you're dealing with procedures that have high variabilities, like we do really well with activities of daily living. But if you have a patient who comes in and says, look, I'm doing well with everything I do. I'm running a 340 when I do a marathon. I really need to do a 320, but I can't do it because I get pain. We can't squeeze that kind of margin out for the highest level individual. So the best professional athlete is one who says, I have problems with activities of daily living, who will say, yeah, I would see value in improving my quality of life, but I would see tremendous value in playing a sport that I otherwise cannot play. So that's the first thing. And then the next thing is, what is the least amount you can do to get them back? Because the less you do in a professional athlete, the less the variability will be due to if you take the variability of one operation, you multiply the variability of the next, all of a sudden you get a very big number in terms of standard deviations. So you got to have your decision-making is much tighter in a professional athlete. It is not always the same. If everything, if you look at the defect, the meniscus status, the alignment, you can't plug those three things in and say you get the same output in a professional athlete that you would get with an otherwise
100%.
individual, right? So, for example, Lonzo was a good example. It's publicly known that he had meniscal surgery in the past, right? So he was doing fine after meniscal surgery, but then developed symptoms that were potentially related to that or potentially not. But the point is that our narrative is whenever you have a meniscal deficiency and you have a cartilage problem, you replace the meniscus to replace the cartilage. But you could make an argument that that's not always true in a professional athlete. You would say, well, maybe you could do a graft, an osteochondral graft or whatever, and not do a meniscus transplant. And with the limitation being it may not last as long. And that may be an acceptable outcome for someone who's in a sport that may not be any longer than 5 to 10 years, for example. So they make a different decision than you or I may make being a high-level recreational athlete. So I think that the take-home is that there's a lot of variability in these procedures. Like you said initially, it is very rare that a professional athlete would fall into this category. And when they do, because of the variability in the outcomes, it's not like an ACL, it's not like a shoulder stabilization. This is different. Because the variability is so broad that the go or no go decision point has to be that they cannot otherwise play their sport at an acceptable level to them or the organization before they decide to embark on this, because any sport that is where an athlete is out for more than a year in terms of A, being allowed to resume high levels of load, and B, to get their skills back, usually that's more than a year to get both those things right. That is a tough. That's the onus of that timeline is can't be underestimated, because that in and of itself may be enough for an athlete never to get back to sport. So they're big decisions, and they're adult decisions that it's complicated by the fact that there's a lot of stakeholders.
Dr.
You
Cole,
and sorry, you go, Will.
No, I was just going to say real quick. I saw the documentary, A Clean Sheet, with Gabriel Landeskog, and that journey from a freak accident from 2020 and his comeback trail, all from leading up to last year. When you have a player at that high level, captain of his team, winner of the Stanley Cup, his team's dependent on him. There's been an investment, and also quality of life, right? New parent, and just trying to get back on. How difficult is it for you personally to see someone go through that, and you're trying to balance, I'm trying to give you quality of life, I'm trying to get you back to the professional level, and making sure that you can do everything possible to help this patient out?
Yeah, I mean, you're hinting at the interpersonal side of it too, because each of these professional athletes becomes a project in and of themselves, because you tend to build a very close relationship with them, because it's not about, as I said before, treating an MRI or a previous arthroscopy or what have you. You're treating a human being whose career is at stake. Mm-hmm. And again, I would say that virtually every high-level athlete, whether it's collegiate level or professional, they were treated because they otherwise were unable or unwilling to do their sport, and this was a go or no-go decision. So that's a monumental thing. It'd be like someone telling me or Grant that, we're going to do this procedure. You're either never going to be a surgeon or a doctor again, or you're going to be a surgeon or a doctor again. Like that's daunting. So, with these individuals, like that's been one of the greatest privileges. Like I'm not one of those sports nuts who can rattle off statistics and things like that. And admittedly, one of my PAs knows anything and everything about sports. When I have an athlete come in sometime, I'm like, can you tell me who he is and the sport? Like
Will's is dying. He loves this. I'm the same way. I have no idea, and Will's knows everything.
I have no idea, but I have much less of an idea than the average bird. And it becomes they really are just like every other patient. But the thing that's so fascinating and so captivating is the decision-making part is really interesting and so multifactorial. And there's just a lot of discussion that goes into it, because at the end of the day, if you're going to do something, you got to really understand the athlete's mentality, and to make sure that they fully understand that what they're about to embark in may not deliver, and they have to accept that. And they also have to accept that it may not be perfect, and that's still a good outcome. A lot of things, and I use this analogy a lot of things we do are off switches. You are broken, you fix it, and then you're good. Like that's the greatest thing about orthopedics. Like there are people who say like, I never thought this would happen. I am perfect. And they're hugging you, and like, that's why people do this. And that's why it's there's so much longevity in what we do, because it's like gasoline. People come in and they're like, they're hugging you, they're bringing you cupcakes, you change their lives. You have impact on someone that you cannot put a price tag on. That decision is with cartilage repair is a little different, because it's more like a light rheostat. It may be a down regulation where they have less pain and can do a whole lot more than they could otherwise do. And that too is a successful outcome, right? Not as compelling as someone where it's an off switch where like, I am perfect. And sometimes they are, but you never go into this with that expectation. And with Lonzo, the ESPN, what they said was, I think they quoted me, I said, this is a Hail Mary. Yeah, it was a Hail Mary. I was unable to say what is going to happen or what is likely to happen.
It's never been done before.
Yeah. And it's
never been done before.
Yeah. What you can say is there's 100% chance that you will not get better, and you cannot play if you do nothing. So we've already proven that with an extended period of time and lots of things that just haven't worked. So now you're faced with this, it might work. And I don't have any percentages to share with you, like I do in other areas. And the problem with percentages is it's binomial. It's either 0 or 1. Like you and I,
100%.
percentages like, yeah, you got a 75% chance of doing well with this, right? That's meaningless to the patient who's either it's going to be or it's not going to be. It's binomial for that. It's either it is or it isn't. So we do population and data statistics, but they're just like an N of 1, and it's either going to work or not going to work. So it's a really fascinating area, but you can't, I guess, and you can't really over communicate, and the privilege of meeting a guy like Gabe or working with a guy like Lonzo and some, I've worked with, tennis players and professional soccer players and the female professional athletes, they're the bomb. Like they'll play with anything. Some of the women athletes that I take care of, and yet there's times where they just can't go. And so a lot of this is the psychological aspect of how they deal with their disease. I'd say that that's probably honestly 50% of it, because we can do a great job, but if they don't have the mindset, and I can tell you each of the individuals we're talking about had the mindset and the mental capacity and the fortitude to go through the rehab and not sort of, for lack of a better term, crap out along the way because of frustration or lack of progress. So that part is really the most fascinating. And that's a privilege to get to know some of these people, to figure out how the soft stuff weighs into a successful outcome.
I wanted to just bring up one point on both these athletes. That's subtle, and unless you're a cartilage surgeon, you wouldn't pick up on it. But both of the surgeries you did in skimp. You did meniscus and cartilage, TTO and patella. And like what you talked about before, is that sometimes you just do the simplest thing. In my opinion, those two, the simplest thing was the patella or the cartilage.
Right.
So what made you, I know there's indications, right? But we're not following the indications of professional athletes. We're doing our best job forward. You went all in on both, even with them being riskier, because you felt like it was the right thing to do. So mentality wise, what were you thinking? Like you're like, we're going to give this the best shot.
The basic thing I was thinking is, what is the least amount I need to do to make them better? And if I don't do that, they're not going to get, in my judgment, level 5 or even level 1 or level 3, they are less likely to succeed. And the additional offerings have acceptable levels of risk. Okay. So you could argue cartilage defect, patella, fix that, should be fine. What if it's not? Got added TTO because there's a fair amount of data for specific defect locations that it's
offloading.
That'll amplify the outcome. What's the cost of that? And what's the relative risk? And is it worth it? And again, this is a little visceral and it's a little level 5 and it's a bit of an art. But like 5 years from now, we'll be able to plug that in and actually get numbers, based upon data. So so that's the end. I think the harder one, honestly, was, do you or do not do a meniscus transplant in a setting where a cartilage defect becomes symptomatic? And it's easy to stand on a podium and say you should always put a meniscus in when they're meniscal deficient and they have a cartilage defect, right? But there is no always. And I could create a very similar narrative to say, leave the meniscus out and just do the cartilage graft. But you say, well, what if the meniscus fails, which is probably the most likely thing that will always fail?
That's an important point.
Sustainability. What's the cost of that? Well, the cost is you do a scope and a clean out, and they may do just fine. So barring no complications from the incremental procedure you add, which is, as I say, lots of variability, you multiply those percentages, you start to get a big number. You got to take that into consideration. The heart of that decision is, I've got to believe that that is what that person likely needs to get better if you're going to drag them through this. And to stack rehab and timelines is not an option often in a professional athlete. You kind of have one shot to offer a big operation, because stacking it together pushes them to 2 years to 3 years. And that becomes a really big bar for any high-level athlete to get back historically, once you're out of your sport for any extended period of time.
I think that's an excellent point for the listeners to hear, that, again, it's all or nothing. You did the right thing.
But you'll never know. But Grant, to your point, I'll never know. What if I didn't do a TTO? What if I didn't do a meniscus transplant? They could have gotten a good result without either one. I will never know, because we used our cumulative knowledge to make, in our judgment, which is not always perfect, in our judgment, to make the best, most informed decision.
Well, by asking the question, I thought that those two were the best decision, but the answer is, it's just, you could see
because you saw a good outcome, but I will never know what would have happened if we didn't do it.
100%. But it's important for the listeners to know that, right? I'm sure they had an opinion, maybe not in your case because they went straight to you and they were happy with it. But these pro
all of
athletes,
these guys had 3 or 4 opinions, and we didn't all align.
I'm sure.
None of these. That's the other thing we should mention is that I will never operate on a professional athlete who hasn't had at least one second opinion in this situation. And
that's perfect. That's a perfect thing for people to hear that,
because we walk through all his opinions, and where we agree to agree, or I'll say, and if I don't agree, I'll say this is where I think we differ here, and it's not about casting shade or other. It's literally saying this is why I think this will work. But this is maybe less likely to work. Remember, there's lots of ways to get something right.
Well, I think the point you made up too is that the second opinion is really important. Like that was one thing in your office, despite how many surgeries we do and non-surgical things we do, second opinion is still something that you if someone wants it, you get it. So you feel more comfortable with the situation.
Or you encourage it.
Exactly. Which is really not all doctors do that. So seeing that, I'm the same way now, like with you. I'm like, you want another opinion, get another opinion. I want to make sure you're comfortable with whatever decision you make.
And we've had that conversation on this show. We've mentioned it numerous times. Get a second opinion. And it seems to me, just with talking with someone like you and other people that we've had on, good doctors are always going to recommend get a second opinion, especially you want someone that's going to feel comfortable about the decision making. They've explored all options. They didn't just rely on google.com to give them suggestions. So that's been a big learning point for it.
As a physician, if we let ego get in the way, we have problems, There's always another patient to treat. So when you're dealing with, especially these types of athletes, it can be challenging. You're never a fan in this instance. You're there to do the best possible service for that individual. This is really important stuff for that person and their family and their livelihood. So ego is absolutely not part of it. And a second opinion is the greatest way to sort of cast that aside.
Awesome. So I know it's getting late. You've been been so awesome having you on. One big question for you. I know you can just do as brief as you want. You talked about the AI stuff. What do you see as kind of this future of cartilage, meniscus, kind of the work you're doing? Like, what do you think kind of the most innovative, interesting thing coming down the pipeline? And again, you don't have to go elaborate too much.
Quick take home sound bites. I think that we've spent a lot of our time and energy focusing on cartilage, but what we're realizing is that most cartilage problems are really load problems, and they're more likely than not bone problems. So by the time patients get to us, it's less about the fact that they're missing cartilage, but more about an osteochondral load problem. And the basis of that opinion is when you think about all the things we do, knee replacement, you could put a dead piece of bone in cartilage, you could put a frozen piece in, losing weight, changing alignment, putting a shock absorber on the inner side of the knee. Those are actually load-reducing procedures and may have nothing to do with biology. So I think paying closer attention to the bone and load is part of our near-term future. I think that determining where we can use responsibly sort of orthobiologics as an adjunct to improve things, that's an obvious one. I think that a focus on allogeneic solutions rather than autogeneic that can be used off the shelf. I think a focus on less invasive things that are injectable or injectable with smaller operations rather than larger operations will be, including office-based procedures that might be beneficial. I think that disease modification is still aspirational. I think we love to talk about it, but we're still a long ways away. So I'm kind of comfortable treating still for the here and now. But if we find something that's disease modifying, that's going to be awesome. The problem is our healthcare system doesn't yet value disease modification, and the FDA makes it very, very difficult to be designated as a disease modifying agent. So still a battle we got to take. As far as AI, I would say that AI is important. I think all of us are going to be. It's not going to replace us, but we will all be working, and we currently are working with AI in situations where it's unbeknownst to us. The place where I think AI will be important is how you and I will leverage the databases that we've been spending all this time and energy, the registries and so forth, taking that data and using generative machine learning models to then make informed decisions on how a patient will do based upon, what if you could plug in, Lonzo Ball, 28 years old, 3 years of knee pain, 2 previous procedures, no kids, body weight this, loves, I'm not saying this is true, loves to play chess. You could plug all of these things in if you collected that data and then use that as a predictor for an outcome. That's what AI will, it's already happening in other industries. That's how AI will help me and you, Grant, is we'll take we'll be able to leverage all that data we're collecting to make an informed decision better than we can do by doing multivariate regression analysis, right? That is tedious and fraught with tons of potential errors and type 1 and type 2 errors and so forth. With AI used responsibly, I think we're going to actually be able to do some really cool things. And it's already being done, but that's why we have to keep collecting data. And you got to collect the right data and make sure that you're compliant. Like, make sure you're getting it at time 0, get it at 6 months, make sure they're filling that stuff out at 1 year, 18 months, 2 years, and longer term. So we can go back retrospectively to look at prospectively collected data and use some engine, some machine learning model to get us there. That's cool. That's going to make a difference.
We got plenty of sound bites from that one. That was awesome. Thank you so much.
Yeah.
Will, anything closing?
Yeah, just real quick. We've talked about mentorship and inspiration throughout all of this, along with all of this plethora of information. I read somewhere, and most young people will know them as Professor Proton or Papa Elf, but some of us that are a little bit older may remember the Bob Newhart show.
That's one of my favorite shows. That was one of my favorite shows.
I read somewhere that you got some inspiration from that show that kind of set you on your pathway to where you're at right now. Can you elaborate that, or am I?
Right. We have some. You guys have some young viewers. So Bob Newhart was a clinical psychologist, so he was dealing with a lot of deeply seated psychological issues. But the guy was funny as hell, and so he blended humor and in a way that also really helped people. And it's interesting, if you look at physicians who are actually sued less, they are more likely to use humor in the office setting than those who are not. There's like a whole litany of literature that discusses litigation in healthcare, and those who can actually engage patients with a appropriate level of humor are far more effective in their ability to sort of meet a patient's expectations and leave them in the end of the day satisfied. So Bob Newhart was just an easy show to watch, and it was a long time ago, but your listeners are, you and I are, I'm probably older than you are, but that was a great show. And that's what he did. And he combined humor and had a huge impact on people.
Thank you, Dr. Cole. Thank you for taking time to spend with us. I know Dr. Garcia is absolute giddy. He's going to be talking about this forever. Dr. Garcia, say goodbye to Dr. Cole.
Thank you very much for coming on. We're looking forward to this.
Yeah, Grant, thanks. Keep up the great work. I'm proud of you. And you're one of my legacies. So I'm really happy with what you've accomplished, and you're thoughtful and you're forward thinking, and just keep doing a great job and taking care of people.
Thank you.
Dr. Brian Cole spending time with us today. We want to just really thank him for his time. Just absolutely amazing. Dr. Garcia, some final thoughts on it before we say adieu to everything else.
Nope. Stay tuned. This is going to be an awesome. People are going to enjoy this episode. More great guests, and listen to it. If you want to be a guest, let us know. We've had tons of requests, but it's going to be hard to top this one. So,
all right. Thank you very much. It was a great show. I'll see you later, Dr. Garcia.